Good morning. Please take your seats. We'll start. First of all, I would like to welcome you in Marseille. I am Michel Laurent-Lyons. I am from the Ohio department in the Cancerology Research Center of Marseille. And I'm really pleased to welcome you here in this room and with my co-chair.
So Austin Kalasekaj, I'm a hematologist from United Kingdom. Thank you.
We will try to keep on time this session. So all questions will be held at the end. So I invite you to mention the name of the speaker you want to ask the question. It will make easier the discussion. And we will start immediately since we are on time.
So the first session is going to be presented by Dr. Amy Dezern on MDS and autoimmunity. Thanks, Amy.
The microphone.
Bonjour and good morning. Thank you so much to the organizers and my colleagues for the opportunity to talk to you about myelodysplastic syndrome and autoimmunity, and to start off a morning of what looks like a fantastic program, and I'm so excited to hear the other speakers as well. I'm sorry, but it won't advance. All right, here are my disclosures. And just very briefly, my role this morning is to provide quite a broad overview of the intersection of MDS and autoimmunity, and I hope to provide context for the talks that follow. So by way of background, I think this audience is certainly aware that coexistence of autoimmune diseases as well as inflammation in patients with myelodysplastic syndrome has been widely recognized for a number of years. And I think increasingly we appreciate the complexity of this intersection, and it's quite a fun time in the myelodysplastic syndrome community to think about this, partly due to prognostic implications, and hopefully towards the end of my talk, some increasing therapeutic implications for our patients. We heard a lovely talk last night about how we need more drugs and we need to understand this better, and I think this is a very good way to think about the disease biologically. Increasingly, we as hematologists are receiving consultations for these patients from other disciplines, and I think that's only going to increase. As we all know, the blood is an incredibly sensitive and important organ system. And as I mentioned, I think that harnessing this disease biology for therapies is very important, and I believe inflammation is really at the heart of all of this. The specific autoimmune conditions that MDS has been linked to are many. You can see the broad diagnoses that fall under the rheumatologic heading in most hospitals here. And you can find the literature for associations for all of these. And I think we're learning that there may be some genetic underpinnings that really link these. And that's, again, part of the fun. The epidemiology throughout the literature has been varied. Most of the largest series are retrospective at this point in time in 2023, but I think that'll only change as we learn more. What's interesting is chronic myelomonocytic leukemia has actually been linked even a little bit more than the broad term MDS, but again, I think this may be splitting hairs, which we'll hear about later in terms of the classifications. Across the series, the prevalence of autoimmune disease in patients with MDS is somewhere around 20%, it looks like. And the majority in retrospective series had the autoimmune condition diagnosed in advance of myelodysplastic syndrome, but I think this may be changing as we have better ways to diagnose MDS in the current era. Historically, because autoimmune conditions have a little bit of a female predominance, that is the link in the MDS literature as well, without a significant difference in age. But again, I think with some of the forthcoming diagnoses that may have a male predominance, this is probably going to change. Historically, International Prognostic Scoring System revised prognostic scores have not really borne out across the different flavors of MDS if somebody had a coexistent autoimmune disease. But again, I think as we use the IPSS molecular more and more, we're going to find more ties here. There are specific mutations, as I list across the bottom, that have been associated quite notably with autoimmune conditions and an increased risk of leukemia. So I always like to bring this back to the patients because that's really where I learn about these. And true enough, all three of these patients have been referred to me in 2023, and here we're only in the beginning of May. So a relatively young female sent by rheumatology after multiple disease-modifying therapies for lupus. A 59-year-old male who with history of joint issues and had been on steroids for honestly the better part of a decade, who had a macrocytic anemia. And then a slightly older gentleman who had had rheumatoid factor negative rheumatoid arthritis, diagnosed in the relative recent time before he was sent to me for his progressive bicytopenias. So just keep these three patients in mind as we talk a little bit more about the biology. The global role of inflammation is something certainly many of you are experts in. We know that inflammation regulates normal hematopoiesis, and we're increasingly learning about the genetic and epigenetic contributions. I really like to think about the specific driver mutations to our myeloid conditions, but certainly the exposure to medications, possibly like our first case of the woman with lupus who'd had many disease-modifying therapies, would be a good example. Increasingly, we appreciate the bone marrow niche probably harbors both protective or not protective environments for each of the mutations, and we'll learn about this. Immunity and chronic immune stimulation are also very important parts of clonal hematopoiesis. Diagnosing the driver really is the challenge, but I also think it's a good part of the fun. And you heard in each of those cases, somebody's 74, maybe aging plays a role. We've talked about systemic inflammation and those acquired mutations, and certainly toxins, but that's really part of the fun as we think through the biology. This is a large but older series from Sweden looking at a large number of patients and trying to understand the role of the chronic immune stimulation as a trigger for the development of myeloid malignancies like MDS. You can see there in the red boxes that the odds ratios for certain diseases like lupus can be as close to 4. And this really shows that these are diagnosed often before in this series with a latency of about 3 years, but certainly increased links. This paper also looked at various infections, again, as a form of chronic immune stimulation to trigger these diseases. A question that I often have when I see patients, such as the cases I presented, is this paraneoplastic pathophysiology? Is the immune surveillance a problem that allows the malignancy to develop, and then the autoimmune comes later, perhaps most like our 74-year-old? Or are there changes to the immune system because somebody has a malignancy and then they have autoimmune sequelae later that are more paraneoplastic? Again, think of that older gentleman who'd had 18 months of rheumatoid factor negative rheumatoid arthritis. But again, I think it does come down to inflammation. Increasing many laboratories throughout the world are looking at this. We know how important homeostasis is for normal hematopoiesis, but when someone ages or has one of these diseases and has chronic inflammation, we're increasingly learning about the stress, both in the niche as well as in the flavor of the clonal hematopoiesis that we know to be malignant, promoting that outgrowth, really due to an imbalance. And I think this is akin even to things like treated aplastic anemia, where you're selecting different clones for outgrowth that may cause a problem to the individual human being. And I do think those mutations that are either there or selected out for, depending how you think about that chicken or egg, matters. This is a lovely picture from quite a recent review from Blood Cancer Discovery that I think really thoughtfully looks at the different mutations and their specific role in the bone marrow microenvironment or the niche, and how these may promote different inflammatory factors. And that's why it is so important for our MDS patients who have a coexistent autoimmune condition or experiencing those symptoms to understand the molecular profile, as we may be able to use this both therapeutically or to explain the biology. Specific to that is many groups throughout the world have looked specifically at the role of splicing in MDS and how this is associated with NF-kappa B activation and inflammation. And again, I think really elegant biologic explanations of this nature are looking at places where we may be able to target the innate immune system therapeutically. You'll hear in a moment from my colleague, Dr. Beck, about VEXAS, that genetics may promote both diseases, and it may not always be the somatic style mutations that I just spoke about. And it's really interesting to think about UBA1 mutations and perhaps other mutations that are out there that could link these together. There's been a couple case reports that I'll just highlight. This one is a bit older, from 2015 in the New England Journal, looking specifically at MEFV mutations in MDS that really had very profound sweet syndrome. And these authors thought that this was all linking MDS and autoimmunity. And then fortuitous for me, there was quite a nice case report that just came out last week about TET2 drivers and NLRC4 passenger variants with adult onset inflammation. And again, what I like about this particular case report story is it helps us think about how clonal expansion driven by a myeloid mutation gene, something like the classical CHIP that we talk about so much, with the passenger mutation may modify those inflammatory signals that we're learning about and trigger the autoimmune syndrome. Certainly we need to learn more about this, but looking for these patterns clinically as well as in the lab will be a very important part of this story because the patients are going to continue to come. So just by way of tying up our cases, the first young woman, interestingly enough, had a TP53 mutation. She was actually called clonal cytopenias of undetermined significance. She didn't meet full MDS criteria in 2023, but certainly she has adverse clonality, as you can see there, that I believe resulted from multiple disease-modifying therapies. The middle gentleman, with his many years of steroids, did have that TET2 mutation, but what he also had is VEXAS, and he's receiving care for that. And then in terms of our 74-year-old gentleman, I think he might be in some ways the reverse, shall we say, is he actually had MDS with XS-BLAST2 that had not been previously recognized as a cause of his cytopenias, and I think all of his rheumatoid arthritis-style symptoms were really that paraneoplastic phenomenon. But certainly once we make these diagnoses, we need to have the ability to offer our patients therapies. And much of the story comes from other drugs and investigations that have looked at how we might modify the various markers of inflammation, what we have as inflammatory drugs, and learning how to halt some of the clonal hematopoiesis progression that could be malignant. Everyone is probably quite aware of the IL-1B story and how aging drives this, and what we've learned from our cardiovascular colleagues about inflammation specific to clonal hematopoiesis and other diseases. And I'll mention a trial that's forthcoming of canakinumab, specifically for patients who have clonal cytopenias of undetermined significance, called the IMPACT study. And it's using canakinumab or placebo, trying to understand how we could modify really inflammation and risk for these patients so their clones don't present as more malignant disease later. So this study is not quite open, but something very interesting to think about as we're targeting inflammation. There's also the emerging NLRP3 inflammasome inhibitor, DFV890, again trying to target the pathobiology of ineffective hematopoiesis. This drug is specifically for those with lower risk myelodysplastic syndrome, and it really is interesting to think about mechanistically, if we're really trying to modify inflammation, how this is going to improve hematopoiesis and hopefully not allow any selective pressure where another clone could have additional outgrowth or problems, but all drugs to help our patients. And lastly, there's X682 and hypomethylating agent failure MDS for patients. And this is a very interesting drug involved in a number of processes, both pathologic as well as normal. And here, if you inhibit the signal with this particular drug, you may be able to improve hematopoiesis. And this is being studied in very refractory, higher and lower risk MDS patients. We don't have a lot of data yet, as not that many patients have been treated, but I think it's still something very interesting to think about mechanistically, both as a single agent and then combined with hypomethylating agents. So this is just a smattering of what's out there. I think there's a lot more to think about as we know that we can target inflammation in the innate immune system with various drugs. And I certainly don't have a lab, but I encourage those of you who do to continue to talk with your clinical colleagues so we make sure that we identify these patients and we can think through therapeutic options for them. And then last but certainly not least, I'd be remiss if I didn't mention that transplantation has a role in both autoimmune conditions as well as myelodysplastic syndrome. This is an older series looking retrospectively at the many refractory autoimmune conditions that were treated with transplant. And you can see lupus, rheumatoid arthritis, and so forth across the bottom. I'm certainly a big believer in transplant for another autoimmune blood condition, aplastic anemia, and I think we have to think about if we're historically using it in higher risk MDS patients, as you see there in the Vidasa Allo trial, if we need to use it in patients that have concomitant diseases. But high risk, high reward, and the more therapies we have, the better our patients can do. So In this broad overview this morning, I hope I've convinced all of you what you probably knew, that clinically and biologically, the inflammatory signaling is very intertwined, and it's going to present in different ways in the human beings, but it's something that we'd really like to modify, both from the hematopoietic system perspective, but certainly from the autoimmune and inflammation perspective as well. Improvements in our understanding with new diseases like VEXAS, and I suspect there's many more, will really help to harness the biology and understanding, as well as move towards translational clinical trials with robust lab correlates. I think this is the future, and we're all looking for more drugs for our patients, and I look forward to hearing the rest of the talks. So thank you so much for your time, and it sounds like questions will be at the end. I'm grateful. Have a good day.
Thank you. We'll move to the next talk, given by David Beck from University School of Medicine in New York about autoinflammation and VEXAS.
Thank you so much for having me here and giving me the ability to share with you about our work on VEXAS and autoinflammation. I have no disclosures. And as many of you know, we published about 3 years ago that genetic mutations in the gene UBA1 cause age-related inflammatory and hematologic disease. And these acquired mutations are found in the earliest stem cells, so they're restricted to the blood, and they're found in the earliest stem cells in patients. And they become lineage restricted into myeloid cells. The mutation is found there, and they're absent in the lymphocytes. And in our initial report, we found 25 patients, but over the last couple of years, there have been over 1,000 patients reported, and we now know a lot more about the clinical manifestations of UBA1 mutations. So these mutations are found predominantly in men with a median age of onset in the 60s, causes severe inflammatory and hematologic condition, so patients are steroid dependent, and they can have very heterogeneous presentations in terms of their inflammatory and hematologic manifestations. So from the inflammatory standpoint, they have overlapping symptoms predominantly, so fever, skin, lung inflammation, but they can meet criteria for different established rheumatologic diagnoses, so like relapsing polychondritis, vasculitis, rheumatoid arthritis. And they also have a predisposition to hematologic conditions. So the vast majority of patients have macrocytic anemia, but they also are predisposed towards myelodysplastic syndrome, so 40% or so, depending on the study, myeloproliferative neoplasm, plasma cell dyscrasia, and also many patients have recurrent thromboses. So as we're learning more about this disease, we're learning that the disease is probably common enough that some of you see them in your clinic. So we've established that the prevalence, at least in some biobanks, is 1 in 4,000 men over the age of 50. All of the individuals that have these UBA1 mutations are affected, so it has 100% penetrance. And the phenotype is diverse. So what do I mean by that? Patients can have clinical diagnoses of in the rheumatologic areas, so lupus, rheumatoid arthritis, hematologic, pulmonary and cardiac, and then dermatologic. Yet they have the same shared clinical manifestations at the core, yet they'll meet these unique subset clinical criteria. So some of what we just heard about could fall into the classification here with UBA1. These mutations can cause a plethora of different clinical diagnoses. And from the molecular standpoint, this disease is quite interesting because it occurs in the new pathway for sort of bone marrow failure with ubiquitination. So UBA1 is the enzyme that initiates the post-translational modification cascade of ubiquitination. And the mutations primarily occur at this methionine 41 residue. And this is the start site for a short isoform of the protein, UBA1B, which is a cytoplasmic isoform. And what we see in VEXAS is that, in these patients, is that there's a loss of the UBA1B protein in the patient mutant monocytes. So this is shown here, the red last 3 lanes. And there's emergence of a new isoform, UBA1C, specifically when this mutation is present. As a result, there's a loss of the ubiquitination in these cells and activation of multiple different stress pathways. So with UBA1 mutations, we see a loss of the cytoplasmic UBA1B and emergence of a catalytically impaired UBA1C. So we name this disease VEXAS for vacuoles, which are highly characteristic in the bone marrow. They're not required. E1 enzyme, X-linked, that's why we see it predominantly in men, autoinflammatory somatic syndrome. And we're learning quite a bit about it because the disease is easy to identify in our cohorts. And one of the first things that we found over the last year was that different mutations in VEXAS actually confer differential survival. So we know that there are 3 different mutations that occur at methionine 41, threonine, leucine, and valine. And we saw that the threonine and leucine patients have higher levels of UBA1B protein and decreased severity, whereas valine has less UBA1B protein and higher severity. So we were able to identify that there's actually an inverse correlation between the level of the UBA1B protein and the mortality in patients. And we think that this is important for thinking about how to risk prognosticate for individuals, and also some of the mechanistic underpinning of the disease, that loss of UBA1B is really the key feature of why there's pathogenesis. So I want to talk more today about new work that we're doing in VEXAS and sort of how we're better understanding this disease, and I'll focus on 3 questions that we're working on. What determines the heterogeneity of disease? What are the inflammatory signals that occur in VEXAS syndrome? And then finally, the genetic mechanisms and the role of ubiquitination in disease. And so this audience does not need any introduction to this. I just want to mention about clonal hematopoiesis. Obviously, it's an acquired mutational process that occurs in older individuals that promotes inflammatory diseases and myeloid malignancies. And the reason why I bring this up is that we thought that some of the heterogeneity that occurs in VEXAS may be because of co-occurring clonal hematopoiesis mutations. So to test this in a collaboration really led by Miran Alpadniak from Mayo Clinic and Bhavisha Patel from the NIH, we looked together at the level of clonal hematopoiesis mutations in VEXAS versus age-matched controls. And as you can see on the right, there was a much higher percentage of clonal hematopoiesis mutations in VEXAS as compared to the controls. And when we look at the mutational profiles in VEXAS patients, we had 83 in this study, we could see that there was 60% of individuals had a clonal hematopoiesis mutation. Of those, DNMT3A and TET2 were the most common. But what was immediately interesting was that these mutations were not more common in the patients that had myelodysplastic syndrome and MPN. Those are towards the left. They were present across all of the different clinical manifestations of VEXAS. So it's not that the clonal hematopoiesis mutation causes the transformation to having MDS. And when we looked at these factors in terms of their risk for mortality, what we were able to identify is that the DNMT3A mutations confer the highest risk for mortality in this hazard ratio. So, and this is even higher than transfusion dependence and thrombocytopenia. So even though this is a small study, and we're just beginning to understand the clinical manifestation, it clues in that some of the severity in the disease is determined by co-occurring mutations, and maybe not so much the MDS diagnosis in this cohort. So we also wanted to better understand the clonal architecture that occurs with these co-occurring mutations. So we took multiple patients with both UBA1 mutations and other clonal hematopoiesis mutations and looked by single-cell genomic sequencing to see if these mutations were in the same clone and the order of these mutations. So this is just one example in which we have a patient with a TET2 and a UBA1 mutation. You can see that the TET2 mutation occurs first, that's the pink cells. And when the UBA1 mutation occurs, that clone is much larger, so those are the blue cells. So in this case, although we don't have consecutive samples, something that we're very interested in continuing to follow, it looks like the UBA1 mutation accelerates the clone, the clonal hematopoiesis clone. Similarly, when the UBA1 mutation occurs first, shown here in blue, and there's a acquiring of a clonal hematopoiesis mutation, those secondary clones do not expand dramatically, again suggesting that the UBA1 mutation is the dominant clone. So we think this is important, not just for how the disease progresses and sort of who to risk prognosticate, but also for whether or not UBA1 should be considered in some of the myelodysplastic syndrome categories and how we should think about treatment for these individuals. So switching gears to inflammation in VEXAS, the patients that we've seen, and maybe many of you in the room have seen, have a really severe systemic inflammation. And when we look at serum from patients, either cytokines, the protein level, RNA-seq in patient cells, we see many different activated pathways. And at the treatment level, no single pathway seems to be effective in terms of an anti-inflammatory response. And this is just data from our zebrafish, in which we can show that knockout of UBA1 or knockout in blue or knockout of just the cytoplasmic isoform in green leads to activation of many different pathways. So we wanted to understand, is there an initial driver pathway that's causing the inflammation? Is there a certain cell type that actually is driving this phenotype? Because that may help us better understand where to treat individuals. And to study this, we use single-cell RNA-seq. So the approach is to look both in healthy donors and VEXAS patients, to put bone marrow mononuclear cells and HSPCs through a gamut of studies, including colony formation assays and single-cell RNA sequencing, to better understand the characteristics in the bone marrow. So as you can see on the right, there is the colony formation units for healthy donor versus VEXAS patient in the bottom, and VEXAS patients are unable to form any colonies as compared to controls. So this is from the bone marrow mononuclear cells. So this is already surprising, because the clone in UBA1 actually predominates within the bone marrow, but ex vivo, these cells are not fit to be able to form colonies. So to better understand what's happening, we looked at the single-cell RNA-seq, and I'm going to summarize a lot of data. Just to say that one of the most exciting parts about our data is that we're able to identify the genotype by single-cell RNA sequencing. So given the position of the mutation, we can assign in 10% of cells whether or not they're wild type or mutant at the M41 position. And as you can see, this is just a control in the populations of which we see the mutation. It correlates with what we've seen by flow cytometry and digital droplet PCR, where the lymphoid precursors are predominantly wild type, and the myeloid erythroid precursors are predominantly mutant. And when we look at the transcriptional pathways that are activated in mutant versus wild type cells, we see, similar to what we've seen in bulk samples, interferon alpha, interferon gamma are highly elevated, and also some cell cycle pathways are elevated in mutant cells versus wild type cells. So through these results, we're able to determine that the mutant cells are actually driving the disease. This has been an ongoing question, whether or not loss of an essential gene would lead to the inflammation or would lead to a non-cell autonomous cause of disease. It's also showing that even when we get granular into specific cell types and to specific genotypes, we're still seeing that there's multiple activated pathways, suggesting that it may not be just one inflammasome, one cytokine pathway that's causing disease. And I just want to finish by talking about the expanding spectrum of UBA1 variants. So we initially had it very simple. There were 3 or 4 mutations that were causing VEXAS syndrome, but now with a lot of the international attention that's happened in large biobank studies, there have been many more mutations that have been identified, and this is beautiful work from the Walter Lab in Germany, looking at the mutational spectrum in myeloid malignancies and lymphoid malignancies. So as you can see in the top, the M41 mutations are found in the myeloid malignancies, but then there's a whole slew of mutations found, somatic mutations, germline, both in lymphoid and myeloid malignancies. So this is interesting, but how many of these are actually drivers? Are they disease-causing? And what is the impact in terms of the pathway? So to study this, we're trying to understand the molecular impact of mutations on UBA1. And just taking a step back here, again, UBA1 is the major E1 enzyme that initiates the whole enzymatic cascade. So there's 2 E1s, they work together with 40 E2 enzymes, and then there are 600 substrate-specific E3s that then regulate thousands of substrates. So UBA1 is really sitting at the apex of this very complex pathway. And so to look for these mutations and to see how many of them were not just present in the myeloid and lymphoid malignancies that were previously reported, we looked in our UBA1 negative VEXAS cases. So we're looking both for new driver genes and new variants in UBA1, and this is a collaboration with Achim Warner at the NIH. And we've looked at, we found multiple recurrent novel mutations in UBA1 that are predicted deleterious. So these are non-canonical UBA1 mutations. So how do these affect UBA1 function? So we're taking a play from a 1980s playbook from Nobel laureate work studying ubiquitin proteasome pathway. And this came from Chinese hamster ovary cells in which they have a temperature-sensitive UBA1 gene. There's a mutation in it that when it placed at heat shock 39 degrees, UBA1 is completely lost, and there's a loss of polyubiquitination. So when you use these cells, this is just showing on the left the control. In the middle lane, we have the heat shock in which there's a loss of polyubiquitination, a loss of UBA1, and then you can completely rescue the phenotype with a wild-type UBA1 construct. So when we use these cells in rescue with all the different variants I just described, what you can see is that all of them show a defect in terms of polyubiquitination, some of them even more severe than the MET41 mutation. So how does this work? Why is it causing disease? So the canonical way that the UBA1 MET41 mutation causes disease is through isoform swap. You can see in the MET41 mutation, there's this new, faster migrating isoform that's UBA1C. All of the other mutations do not create the new isoform. So UBA1C is not required for VEXAS syndrome. When we look at the in vitro activity with recombinant proteins, we can see that the E1 ubiquitin charging is impaired in some mutations, whereas the E2 transfer, the second step in the process, is impaired in all mutations. So to summarize this part, UBA1C is not required for VEXAS syndrome. We see in some cases that there's defective first step thioester activation, and that actually some of the unique aspects of these mutations, two of them form intramolecular ubiquitination events that alter the structure of the protein, which I didn't have time to talk about. But the disease mechanism seems to be loss of E2 transfer. And they're going to be, we hypothesize that there are specific E2s that mitigate the pathway and the phenotype in VEXAS syndrome. Just to close, a lot of the efforts in my newly established lab are studying mouse models of VEXAS in which we can already recapitulate with a conditional knockout and knock-in strategy the inflammatory pathways that are elevated in this disease. So we're hoping this will be a big step forward for treatment and sort of the disease initiation. So with that, I'll just conclude by saying UBA1 mutations are now well established as a driver of clonal cytopenias, and even within some of the MDS working groups and classifications, which we'll hear about today, it's now has its own, it's characterized within those classifications. UBA1 and CH mutations confer worse survival. The mutant cells drive inflammation in VEXAS syndrome. And then finally, the novel mutations highlight the importance of the E1, E2 binding in disease. And just to close, it's been really incredible to be embraced by the hematology community with this genetic discovery, and a large part that's been by international attention in France in particular. And this is just to highlight the International VEXAS Working Group, which many of you may be involved in, led by some of my French colleagues. And it's just great to see because there's a lot of unknown answers, and working together, we're starting to get to some clear guidelines. So I'm appreciative, and I know patients are really appreciative of this effort. And we'll be able to provide better answers soon as a team. Thank you so much for your time, and thanks for all the people that contributed.
Thank you, David, for that. And we'll move on to the next talk, which is clonal hematopoiesis from healthy persons to leukemia survivors, from Klaus Metzeler from the University of Leipzig. Thank you.
Dear colleagues, good morning. It's an honor to be part of such a great group of speakers, and I'm happy to be able to present you some of our work on clonal hematopoiesis. And I will try to take you on a journey today from the very early steps of clonal hematopoiesis in healthy older adults to the other end of the spectrum, which is persons who have already progressed to a myeloid malignancy and actually survived AML treatment. And I'm going to show you some of our data on clonal hematopoiesis in this population. Here are my disclosures. So from the early days of clonal hematopoiesis research, which is now already almost 10 years ago, we know that the prevalence of clonal hematopoiesis increases with age. And these early studies reported that 10 to 15% of persons over the age of 70 will have detectable clonal hematopoiesis. And this is a number that you can still often read in manuscripts or reviews on the topic. However, quite early on, it became clear that if you look more closely, using a more sensitive assay that will be able to detect smaller clones, then the prevalence of clonal hematopoiesis is higher, in this study already 25% in the 60 to 69 year age group. So probably the closer you look, the more you will find. And in a work together with Katharina Götz's group, who is also in the room here today, we were able to look at that in a cohort of 200 older patients who underwent hip replacement surgery, median age around 70 years with no known hematologic disease. We did targeted sequencing of myeloid driver genes with a sensitivity of around 1% allele frequency. And indeed, we identified clonal hematopoiesis in 50% of these participants with a strong age dependency. And in fact, 85% of those over the age of 80 had detectable clonal hematopoiesis. And of note, 40% of those with clonal hematopoiesis had more than one detectable mutation, and there was a trend towards higher allele frequencies in those with more than one variant. Now you can look at this in even more detail in this very important and exciting study published last year, where the authors looked at individual hematopoietic stem cells, or HSC colonies, from individuals across a broad age range. And what they did is they performed whole genome sequencing on 200 to 400 individual stem cell clones from these individuals. And in the upper example, you can see stem cells from a younger individual, which are highly polyclonal. But in the lower part of the diagram, you see stem cells from an older individual, and you can see those family trees of stem cells which are linked by shared mutations, indicating that if you look at more of these patients, clonal hematopoiesis seems to be quite universal in persons over the age of 70. And notably, those are not single clones per individual, but those authors found 10 to 20 different clones per individual that collectively make up for 30 to 60% of total hematopoiesis. And if you track back the ancestry of these clones, most of them originate early in life, and they carry no known driver mutations, meaning that we will miss most of these clones if we use targeted sequencing approaches. So really what we are looking at in most of the current studies looking at CHIP may be the tip of the iceberg, in that genome or exome sequencing approaches, which are commonly used in many of the large cohorts that are being analyzed, with a sensitivity of maybe 5 or 10% allele frequency, detect clonal hematopoiesis in 10 to 15% of the over 70 age group, the number that you're often reading. But if you look with more sensitive assays like targeted sequencing, that frequency increases to around 50%. And if you get even more sensitive using error-corrected sequencing or single-cell approaches, clonal hematopoiesis seems to be near universal above a certain age. So one question that we found interesting in this context is how much are we actually missing potentially by just looking at peripheral blood, which most studies do for obvious reasons. And our study of patients undergoing hip replacement gave us a chance to look at this because we had a mix of bone marrow and blood samples. And as you can see on the left side, the allele frequencies that we identified in the bone marrow or blood compartment were actually pretty similar. And for a subset of these patients on the right, we also had matched bone marrow and blood samples, and you see a quite good correlation between these two compartments. And importantly, if we look at clonal hematopoiesis carrier status per patient, there was a 100% concordance between peripheral blood and bone marrow, meaning that probably we're not missing a lot of clonal hematopoiesis by just studying blood samples. Another interesting insight from that study is that we could actually look at spatial heterogeneity of clonal hematopoiesis in different anatomical sites. And this is because a subset of these patients actually underwent simultaneous bilateral hip replacement, meaning we had 2 bone samples obtained from the same patient at the same time. And 8 of these patients had detectable clonal hematopoiesis, and you can see that in 2 of these samples, we actually detected a discordant mutation spectrum in the 2 anatomical locations, both times affecting ASXL1 mutations that were detectable on one side, in one bone sample, but not detectable or just borderline detectable in the other specimen. Now, when you're doing this by NGS, and there's similar data from Lucy Godley's group showing us similar results, you always have to keep in mind that this could be an artifact of your assay just missing to pick up the mutation. So we also established droplet PCR assays to validate these results, and those confirmed that there was at least a 15 to 20-fold difference in clone sizes between those 2 anatomical marrow sites. So of course this raises the interesting hypothesis, despite the obviously small numbers, whether expansion of clonal hematopoiesis clones may actually begin as a localized process within certain bone marrow sites. So to sum up that first part, I've shown you that clonal hematopoiesis is probably near universal above the age of around 70 years. However, the detection of clonal hematopoiesis mostly depends on the assay that we're using, both in terms of scope, targeted panels versus genome-wide approaches, as well as in terms of sensitivity. And for this reason, between study comparisons of clonal hematopoiesis prevalence and its clinical correlations are problematic. I've also shown you that clonal hematopoiesis clones may show spatial heterogeneity between different marrow sites. And with that, I now want to change gear a little bit and take you to the other end of the spectrum of clonal hematopoiesis, if you wish, because we know that in some patients, clonal hematopoiesis can progress through the acquisition of additional mutations to a myeloid malignancy such as AML. And we've known for many years, and we've also studied this in our group, that if patients with AML receive induction chemotherapy and achieve a complete remission, then clonal hematopoiesis can persist in these individuals who have morphologic remission of their leukemia. And we were now interested in what is happening to those persisting clones after leukemia treatment in long-term survivors of leukemia. We were able to compile a cohort of almost 400 AML long-term survivors. All of them were more than 5 years after their initial leukemia diagnosis. And we used a more sensitive assay in this analysis, which was able to pick up clones with an allele frequency of 0.1 to 0.5%. Overall, we found a high prevalence of clonal hematopoiesis, 62% if we count variants with an allele frequency of over 0.5%. But also in the very early steps of the analysis, it became clear that there are strong associations with patient age, time since treatment, and also type of AML therapy received that required us to do stratified analysis. So here we are looking at clonal hematopoiesis according to the type of AML treatment patients had received. Excuse me. And the left bar shows you patients who had only received cytotoxic therapy without an allogeneic transplant. The right bar are patients who had received allogeneic transplantation. And you see that the prevalence of clonal hematopoiesis is much higher in those persons who had received chemotherapy without allogeneic transplantation. Also, if we look at the number of mutations, this was higher in patients who received chemotherapy without allogeneic transplantation, the violet bars versus the green bars. And the allelic frequency of variants also tended to be higher in patients who had received chemotherapy but no allotransplant. If we now factor age into these analyses, then you see that among patients who received chemotherapy without allogeneic transplantation, we observed the expected age dependency or age-dependent increase in clonal hematopoiesis. However, no such increase was seen in patients or AML survivors after allogeneic transplantation, where of course we are looking at donor hematopoiesis at that time point. In contrast, in patients who received only chemotherapy, there was no association between clonal hematopoiesis and time since treatment. However, in patients after allogeneic transplantation, clonal hematopoiesis increased with time since transplant. The mutation spectrum also was different between these two groups. Overall, DNMT3A and TET2, not unexpectedly, were the most common variants. However, mutations in TET2 and PPM1D were found much more commonly in patients who had received chemotherapy without allogeneic transplantation. And again, not surprisingly, those variants are known to accumulate in patients who have received cytotoxic treatment. Importantly, this cohort also gave us a chance to study associations between clonal hematopoiesis and somatic comorbidities in AML survivors. And to our surprise, but maybe also due to the relatively small patient numbers, we did not detect any associations between clonal hematopoiesis and coronary artery disease, congestive heart failure, or myocardial infarction. However, what we did find was associations between clonal hematopoiesis and diabetes, and also the development of secondary neoplasms in AML survivors, although the latter may be confounded by age and time since treatment. So we were specifically interested in the association with diabetes, and we had a closer look at that. And as you can see here, the association with diabetes was most strong in patients after allogeneic transplantation, and also for those with larger clones with an allele frequency of over 2%. And if we look at the mutations that are involved here, it seemed to be specifically TET2 mutations that are enriched in AML survivors after allogeneic transplantation that developed diabetes. And this is unpublished data that we're currently investigating further, trying to understand this association in more detail. So with that, let me summarize the second part of my presentation. I've shown you that clonal hematopoiesis is very common in long-term survivors of acute myeloid leukemia. It affects 75% of those who were treated with chemotherapy alone and 50% of those who had undergone allogeneic transplantation. The type of therapy modulates the mutation spectrum that we observe, with TP53 and PPM1D mutations being more often found in patients who did not undergo allogeneic transplantation. And we found clinical associations of clonal hematopoiesis with diabetes, specifically in survivors after allogeneic transplantation, and potentially also with secondary neoplasms. And this was mostly observed in persons who did not undergo allotransplantation. With that, I want to thank everyone in my group and our collaborators who helped us generate these data. Luisa Hartmann, Katharina Götze, Judith Hecker, Eva Telzero, Simon Klaus are the main people who did this work. I want to thank you for your attention, and I hope we can have questions at the end of the session. Thank you very much.
Thank you. We will move to the next speaker, Uwe Platzbecker from the University of Leipzig, who will talk about therapeutic targeting of inflammation.
Good morning, everybody. It's a great honor and pleasure to be here. And I still have 10 minutes left, I guess, maybe 14. Okay, thank you. And what I will do is actually give a little bit an overview on the therapeutic targeting of inflammation. And I can actually rely on the excellent presentation also of my colleague, Dr. Dezern, who already introduced you into the topic of the potential targeting of inflammation in MDS. So where are we at the moment with precision medicine in MDS. I think we have made great advance in the last couple of years and have identified potential targets and also identified potential therapeutic interventions. However, I think many of these agents are not approved or are currently in late-stage development, but I think we have definitely made a significant advance in the last couple of years. So what about targeting the immune system? Alterations of the immune system are known in MDS, and I will basically start my presentation a little bit what is known and also what is currently done in the arena of therapeutic agents. So I think therapeutic agents intervening with the alterations of the immune systems have rather be explored by serendipity in MDS patients like ATG, cyclosporin A, with a definite overlap also to aplastic anemia, showing sometimes durable response rates in a still very badly defined subgroup of low-risk MDS patients. Also, Campeth has been explored, including also cytogenetic responses. And I think the reset of the immune system can be very successful in a platform called allogeneic stem cell transplantation, which of course is a very robust reset with some side effects, graft versus host disease and others, as we know. There have been plenty of trials with immunosuppressive therapies. Just as an example, temsirolimus modulated some immune alterations like regulatory T cells, but did not induce a response. This is just a recent experience also with daratumumab targeting CD38, also regulatory T cells, but also NK cells. You see that the target was hit, basically numerically changes of immune cells in the blood of these patients. However, this did not result in any hematologic response in these patients. So the question is then, are the alterations of the immune system a culprit or a bystander? So what is basically known here, and I think we all agree here in the room that MDS, but also AML, is a disease of the elderly where chronic inflammation is a well-established predisposing factor in general also for cancer, and this is termed, or the terminology used for this is so-called inflammaging, where stressed damaged cells release endogenous inducers of sterile inflammation, so-called DAMs, including also S100A proteins. And this is also seen in the context of upregulation of toll-like receptors, but also receptors which can actually sensitize these alarmins like NLRS or NLRP receptors. So this is, I think, something which is quite known and well established for elderly patients, but it's also known now that this is quite frequent in MDS patients. We also have seen already the association of MDS with inflammatory and autoimmune diseases shown here, the French experience. I think this is something we have not recognized before, but now it brings an interesting pattern also, and also potential therapeutic implications. And we also have seen that in these patients with systemic inflammatory autoimmune diseases, there's also a pattern of certain mutations like IDH1, IDH2, and also linked to alterations and disruption of T cell hemostasis. So in turn, one may speculate that targeting these mutations quite specifically may also change these alterations of the immune system. VEXAS is, of course, a very interesting overlap syndrome, which I think you have heard a lot in the excellent presentation before, but I think this will also give us some insights, better insights into the pathophysiology. In general, I think with regards to the terminology, we have to differentiate between autoinflammation on one side, but also autoimmunity on the other side, which is rather a dysregulation of the adaptive immunity. But I think we all agree that there is a mixed pattern disease, that MDS is a mixed pattern disease, that it's basically both of everything, and we need to elucidate what is the potential druggable alteration here. Current understanding is that MDS starts already, or let's say changes of the immune system already start at the state of clonal hematopoiesis with increase of inflammatory cytokines, IL-6, IL-1 beta, induction of pyroptosis, so kind of smoldering inflammation, which turns the disease then into lower risk MDS. Also genetic instability is the result of this, but then at a later time point, higher risk MDS AML, there's more an expansion of an immunosuppressive state with an expansion also of regulatory T cells, but also myeloid-derived suppressor cells, or so-called MDSCs. We know that these alarmins are overexpressed and can be found in the bone marrow, but also in the elevated in the blood or plasma of our patients, irrespective of cytogenetic abnormalities, predominantly in low-risk patients than in high-risk patients. And you definitely know that also the niche is involved. The niche obviously is hijacked by the malignant hematopoietic clone and secretes these alarmins, and vice versa, induces via toll-like receptor ROS production, DNA damage response, and cell death, leukemic evolution as a potential result. So the question is, are these well-known alterations of inflammation, but also autoimmunity, potentially druggable? Well, S100A, as you can see here, is not only secreted by MDSCs, but is also in turn, in an auto loop, is also promoting expansion of MDSCs, while the inflammasome can also activate a toll-like receptor. And indeed, there are now agents in early development in myeloma, basically targeting S100A. On the other side, we also have evidence from currently approved agents that, like lenalidomide in this case, that via direct or indirect mechanisms, S100A levels can be lowered in the bone marrow of our patients. Other developments are shown here, like B-specific antibodies linking CD8 T cells with CD33 high expressing MDSCs. So the elimination of MDSCs as a potential targeting of the inflammatory microenvironment in the bone marrow of patients. IL-1 beta is, of course, has been shown to be overexpressed, abundantly expressed also in high-risk MDS, but especially in low-risk MDS patients, and a well-known and already kind of approved, not an MDS, of course, antibody is canakinumab, which actually had been pioneered predominantly as an IL-1 beta strategy in patients with cardiovascular disease, preventing major cardiovascular events. I think the results of this study are well known to you, but there was a recent publication with a subgroup analysis of this trial showing that patients predominantly with a TET2 mutation, so these were actually cardiovascular patients, not MDS patients, so CHIP patients with the TET2 mutation had the most benefit from canakinumab treatment. So linking inhibition of IL-1 beta and also maybe potential benefits also to clonal hematopoiesis and to certain mutations, which of course has to be shown in MDS patients. In fact, Guillermo Garcia-Manero's group showed at the last ASH meeting that canakinumab is actually active in lower risk MDS patients. You see over response rate 16%, also some side effects. Activity, I think, was considered to be modest, but I think it's a proof of concept that the modulation and the inhibition of IL-1 beta may be beneficial, and this could be a backbone for a still to be defined subset of patients where not monotherapy but maybe combination therapies may be interesting, maybe an interesting approach. Apart from this, other, of course, opportunities may target MDSCs, also stromal cells, macrophages. I think everything, or there are a lot of agents now in the pipeline, but something which is really interesting is the IRAK4 inhibition. We know that the IRAK4 pathway is activated in myeloid progenitor cells in MDS, but also AML. So this pathway is part of the innate immunity, but is basically co-opted by these progenitor cells, and also spliceosome mutations seem to provoke a missplicing in favor of the IRAK4 long isoform. Therefore, the inhibition of this pathway is currently evaluated in high-risk MDS and AML. Already data have been presented, but also this agent is currently explored in a low-risk MDS trial in Germany. Other agents currently in even phase 3 program, roxadustat, is an inhibitor of the inhibitor of HIF-1 alpha, so a PHD2 inhibitor, and has been shown to be more effective in CKD patients with regards to anemia. But what is also shown, or what has been shown recently in CKD patients, is that roxadustat may also dampen the autoinflammation in these CKD patients, also by lowering hepcidin levels in these patients, and given the rationale also to lower hepcidin levels, so providing more iron to the erythropoiesis, this may also a mode of action of roxadustat, so as a kind of anti-inflammatory agent, which comes along with the administration of this agent in low-risk MDS patients. The expression of immunosuppressive cytokines, TGF-beta, IL-110, of course, leads to the dysfunction of cytotoxic T cells, reduced proliferation, deficits in pro-inflammatory cytokines, and at the same time also the expression of inhibitory immune checkpoints is upregulated. We know this for PD-1, PD-L1, TIM-3, of course, so this is maybe all linked together, but I think you know that some of these like PD-1, PD-L1 targets have been explored in clinical trials already with antibodies, unfortunately not very successful. Recent examples include TIM-3, sabatolimab, for instance, or CD47 as another checkpoint predominantly for macrophage function, which look actually quite promising. Last but not least, the inflammasome activation is pretty well known in especially low-risk MDS patients. The cascade leading to pyroptosis via the caspase-1 activation and also IL-1 beta secretion. This has been shown for the first time, I would say, in a very concise way in 2016 by Alan List's group. You see here that NLRP3 upregulated, especially in low-risk MDS patients, also caspase-1, giving the rationale also to target this pathway. I think that the situation is maybe a little bit more complex than an on-off low-risk, high-risk. We just analyzed a large group of patients also from a genetic background, including CHIP and non-CHIP patients. Just if you are interested, Marie Schneider is presenting a poster here at this meeting. We also know that the inflammasome activation in MDS can be measured by a plasma spec expression, and it's actually a reflection not only of low-risk versus high-risk MDS, but also of the number of mutations. So the higher the number of mutations, the more obviously the inflammasome activation takes place. And last but not least, and this Amy nicely introduced this to you already, there is a very specific NLRP3 inhibitor already clinically available, where the clinical trial in low-risk MDS, but also CCAS patients is about to start. This is the first COVID slide I have seen at this Congress, although you all remember there was a pandemic in the last 2 years. So this agent actually had been explored in a randomized trial to dampen the inflammatory response to COVID in patients with the COVID infection. You see that CRP levels, IL-6 and others were actually significantly lower in this patient. So maybe this kind of therapy may have a broad spectrum of activity also beyond MDS. So stay in time, I have 21 seconds to summarize where I hoped that I could show you the clear evidence for the involvement of the immune system into the pathophysiology of myeloid neoplasm / MDS, whether it's culprit or bystander, whether it's druggable or not, whether it's prognostic or predictive. I think we talk about IPSSR, IPSSM, great advances, but I think the immune system, I think, should be also an instrumental part of maybe the prognostication of these patients, and this will in turn open the era of targeted therapy to my understanding at this stage, still to be defined subgroups of patients. With that, thank you for the attention and happy to take questions later.
Thank you for that. We have a slight change in the program, so the second selected abstract, if that's okay with the first author to present first. So it's Cesario Gialongo from Italy, from the University of Catania, and the co-authors to present their data on macro H2A 1.1 sits at the interplay between epigenetics and inflammation of mesenchymal stromal cells in myelodysplastic syndrome. And sorry, thank you so much for accepting the change.
Thank you very much. Thanks for scientific committee for selecting our work. I have nothing to disclose. Bone marrow microenvironment is composed by several cell types, including mesenchymal stromal cells that are important to maintain hematopoietic stem cell. The pathophysiological causes of myelodysplasia are several, including both intrinsic somatic mutation in myeloid progenitors and extrinsic factor affecting bone marrow microenvironment. In this context, it has been demonstrated that MDS mesenchymal stromal cells from MDS patients are dysfunction, and in particular, their crosstalk with MDS initiating cells provides a fertile soil for the development of the MDS triad, including the cross-regulation between inflammation, tumor cells, and bone marrow microenvironment. Epigenetic dysregulation are key contributors to mesenchymal stromal cell dysfunction and their associated tumor phenotype. Of note, MDS mesenchymal stromal cells maintain their dysfunction after expansion ex vivo, suggesting an inherited epigenetic dysfunction which endures despite removal of disease-associated macroenvironment factor. MDS bone marrow microenvironment are more hypermediated than healthy stromal cells, and this hypermedylation status increases from lower risk to higher risk patients. Among the epigenetic protein involved in the organization of heterochromatin, macroH2A1 is a histone variant of H2A histone. It has two different splicing isoforms, 1.1 and 1.2. In particular, 1.1 it has been demonstrated to be a stronger regulator of gene transcription, DNA repair, and negatively correlates with stem cell self-renewal. Evaluating expression of macroH2A1 in biopsy specimen from MDS patients and age-matched controls, we observe an increased expression of the histone variant in MDS patients, and mesenchymal stromal cells were among the macroH2A1 positive cells. So we next investigated if MDS mesenchymal stromal cells upregulated the macroH2A1. In particular, we discriminate the expression of the two different isoforms, 1.1 and 1.2. We found an upregulation of 1.1 isoform in MDS mesenchymal stromal cell that was confirmed by immunofluorescence. In agreement with the inflammatory bone marrow described in MDS patients, a metabolic analysis of MDS mesenchymal stromal cells highlights an overexpression, an increased level of nitrite and nitrites, GSH, NADP, and NADPH ratio in MDS mesenchymal stromal cells, suggesting an adaptation of these cells to the inflammatory macroenvironment. And this adaptation was also confirmed by upregulation in these cells of TLR4, that is a marker of pro-inflammatory mesenchymal stromal cells. Of note, TLR4 and 1.1 expression were related. So we next move to understand the correlation the correlation between the expression of TLR4 and 1.1. For this reason, we induced the upregulation of 1.1 in healthy mesenchymal stromal cells and observed that 1.1 overexpressing cell increase TLR4 expression and activate its signaling pathway. Proteomic analysis highlights several proteins, both up and down-regulated in 1.1 overexpressing cells, and the pro-inflammatory proteins associated to activation TLR4 pathway were among the upregulated protein. Moreover, this pro-inflammatory response was associated to a senescent-associated secretory phenotype, as demonstrated by the upregulation of pro-inflammatory cytokines at increased level of gamma H2AX. Moreover, we found also the upregulation of epigenetic modifiers. For instance, S-adenosine homocysteine is the only one mammalian enzyme able to hydrolyze SAH, that is a strong inhibitor of methylation process. Cells upregulating S-adenosine homocysteine have an hypermethylated DNA. In agreement, we observed that in our 1.1 overexpressing cells, SAM-SAH ratio and 5-methylcytosine were increased. Moreover, also chromobox 3 was upregulated. Chromobox 3 is a methyl reader associated to heterochromatin. It recognizes H3K9 3-methylated histone that was confirmed to be upregulated by Western blot analysis. Moreover, 1.1 overexpression induces a metabolic reprogramming of healthy mesenchymal stromal cells, inducing, as suggested by the upregulation of LDHA, that is a key enzyme of glycolysis. And this metabolic reprogramming was confirmed by metabolic analysis. Following a strong oxidative stress, LDHA can translocate into the nucleus following a non-canonical pathway associated to hypermethylation of histones. In our model, we observed that 1.1 overexpressing cells increase their nuclear LDHA level associated to enhanced oxidative stress. This increased nuclear LDHA was also observed in MDS mesenchymal stromal cells. Overexpression 1.1 in healthy mesenchymal stromal cells also impaired their hematopoietic support capacity, as demonstrated by the reduced number of CD34 positive cells from co-culture with mesenchymal stromal cell upregulating 1.1. Moreover, this hematopoietic stem cell isolated from this co-culture also showed a reduction of their progenitor function. Finally, since azacitidine, it has been demonstrated to exert its anti-leukemic activity, in part improving the MDS mesenchymal stromal cell capacity to support hematopoiesis, we investigate the effect of this epigenetic drug on 1.1 expression. We found that both 1.1 TLR4 and its pathway were downregulated after treatment with azacitidine in healthy mesenchymal stromal cells. And these data were also confirmed in MDS mesenchymal stromal cells after treatment with azacitidine ex vivo. In conclusion, our data demonstrate that among epigenetic modification affecting MDS mesenchymal stromal cells, the upregulation 1.1 induce a suspend TLR4-associated pro-inflammatory phenotype, increase the methylation capacity of these cells, induce a metabolic reprogramming, and this modification altogether impair the hematopoietic support capacity of these cells, sustaining the development of MDS triad. Finally, I would like to thank my research group for their support and everyone for your attention. Thank you.
Thank you for keeping on time. So we will now have the last speaker of the session, Stephen Nehmer from the University of Miami. Stephen.
Good morning, everyone, and thank you for selecting my postdoc, Xuan Chen's abstract for presentation. We come to these meetings to learn about science, and I think there's some life lessons as well, such as dealing with jet lag. Xuan got his PhD from the University of Miami, joined my laboratory. He's about to be a pathologist at Mayo Clinic, and so I'm thrilled to present his work on his behalf. So he's been studying a TET2 knockout mouse model of MDS and has uncovered a role for a molecule, NLRC4, part of the inflammasome, which is linking innate immune signaling and epigenetic reprogramming. Okay, and I have nothing to disclose. So we've all seen the role of the acquisition of mutations early and later in the MDS pathogenesis, how these are selected for, how the disease progresses. Clonal selection has been studied by many people. This is a figure from one of Ben Ebert's papers, just looking at how the process occurs. And there's been a lot of interest and attention focused on how inflammation or infection can drive the process. There's a really wonderful review from Yannis Iafantis last month in Blood Cancer Discovery, and so I stole a couple of the figures from him. And this is one which places inflammation at the center of one of the hallmarks of cancer type slides, showing how inflammation can alter stem cell biology, the immune environment, the microenvironment, all contributing to the initiation and progression of myeloid malignancies. Also, another figure from his paper shows that each of the different mutations has been established so far to set up different pathways, which some involving TNF, some involving IL-1, IL-18, CXCL12, and others to drive stem cell proliferation or impair differentiation and maturation. So we've been studying TET2 in our lab on our floor of our research building. It's one of the most frequently mutated genes in MDS, and it encodes a dioxygenase that demethylates methylcytosine. And so it's involved in suppressing inflammation in innate immune cells and in hematopoietic stem cells. And we've used a model from Ming-Jiang Zhu, which is a TET2 null mouse model. And we administer for 4 weeks a microgram per gram of LPS twice weekly for the 4-week period. And then we study either those cells or we transplant those cells into recipient mice. So the first thing we find is that the TET2 deficient mice have a myeloid bias and some evidence with increased neutrophils, decreased lymphocytes compared to the wild-type mouse. And if you give the mice LPS, you further develop a myeloid bias. Also, the TET2 null mice by themselves have elevated inflammatory cytokines. There are 4 columns at the bottom. The first is just wild-type cells treated with PBS and wild-type mice treated with PBS. Then you have wild-type mice treated with LPS, and you can see that a variety of inflammatory cytokines begin to be expressed. The TET2 treated with PBS look very similar to the wild-type treated with LPS, and then there's synergism between TET2 loss and LPS with a marked increase in inflammatory cytokines. If one looks biologically at what are the effects of this, one sees that mice that receive a 50-50 mix of normal and either wild-type or TET2 null HSPCs, only the mice that receive the LPS-treated TET2 null HSPCs develop a syndrome that is apparent within the first year, and these mice die of MDS. You can see in the middle panel the low platelet count, and the mice don't do well. They lose weight, and they develop an MDS phenotype. So if you look in the peripheral blood, you see dysplastic cells. If you look in the spleen and in the liver, you see inflammation periportally in the liver and elsewhere, and this inflammatory infiltrate is composed primarily of myeloid cells. So we then did serial transplantation to look at the stem cell biology and try to understand why these cells develop MDS. And what we identified is, first, as is known, as the TET2 deficient HSPCs. One, they serially transplant better than wild type. But two, although early on we see an increased competitiveness, over time, the TET2 deficient cells that are treated with LPS actually exhaust. And so if you look, this is looking at the CD45.2 marker, which is a marker of the donor cells. And of course, the screen's a little too far for me to read the percentages, but you can see in the short term an increased number of CD45.2 in the TET2 null. You do the secondary transplants, and you begin to see some of the early exhaustion. And then by the third round of transplantation, there's very few, as you look at the numbers in the lower right of this, there's very few stem cells at the tertiary transplant in the mice that have received TET2, LPS-stimulated TET2 null cells. And if you look down at the LSK compartment, you in fact see an early exhaustion there, and that's just demonstrated on this quantification graph. And in the bottom right again, you can see there's almost no stem cells, which is why these mice die of, one of the reasons why these mice die of MDS. So we were very interested in understanding from gene expression profiling what was going on in the mice, and so we did RNA-seq and identified a few interesting molecules, and the one that we focused in on particular is NLRC4. There's great attention to NLRP3, which is also involved in inflammasome signaling, and we focused on NLRC4. You can see there's a number of other pathways that are upregulated in these cells, epigenetics, inflammation, innate immunity, all pointing to a link between these two events, epigenetic control of these signaling pathways. So the first thing we did is we took the TET2 deficient HSPCs and we knocked down NLRC4, and what you see is here you can see the colonies where in the wild type cells there's really not much of an effect of knocking down. We have two different shRNAs to knock down NLRC4, but on the in the TET2 null you can see first of all at baseline a marked increase in the number of colonies, which diminish when you knock down NLRC4. We then turned to some of the data sets on patients with MDS, and in fact we found that patients with TET2 mutations but not DNMT3A or ASXL1 have evidence of upregulation of IL-18 and NLRC4 expression, and again, some of the same pathways, different analyses identifying innate immunity and inflammasome signaling is upregulated in the TET2 null. We then used two models. I have data from Schwann on one of the models. The other, I think he's hopefully in the lab right, well, it's, I guess 4 o'clock. It's a little early to be in the lab, but hopefully by 6 a.m. he'll be in the lab. And one of them is this MDS-L human cell line, which mimics MDS. And so we knocked down NLRC4 in this situation. First, NLRC4 seems to be overexpressed in the MDS-L line compared to normal CD34s. And then when you knock down NLRC4, you see a marked decrease in the number of colonies that occur. The final model that we're using is there's an inhibitor called C77, which is both an NLRP3 and an NLRC4 inhibitor, and we're analyzing these mice, the TET2 null and mice treated with LPS alone or the inhibitor alone, or LPS and the inhibitor, and we've also generated now, getting from Richard Flavell, NLRC4 null mice that we're generating the double knockout, and we'll soon have information on that. So the working model is, of course, that mutations occur within the hematopoietic stem cells. They themselves set up a mutation-specific changes in their microenvironment, and then part of this involves different inflammasome components depending on the mutational status, and we do believe that NLRC4 may be a useful target in MDS, similar to what you've heard for IRAK1/4 and other molecules that are involved in these pathways. So sitting at the head of the table here is Xuan Chen. This is a typical winter in Miami, and I want to thank him and all his hard work and the other members of my lab who have participated in this work, and thank you all for listening to my talk.
Thank you so much for all the speakers and the two abstract presenters as well. So we think we got 5 minutes, and a couple of rapid questions would be great. If you could identify yourself and come to the microphone, and also please say who you want the question to be answered, so the speakers can also make their way to the microphone.
Okay, this is Pierre Fenot. I introduced myself yesterday, I think. It's just that several drugs potentially working in patients who have both MDS, CMML on the one hand, and autoimmune or autoinflammatory diseases were quoted this morning. Perhaps one, which we all know was not quoted, which is azacitidine. And the GFM, in conjunction with our internist colleagues, published recently a prospective phase 2 study showing that in those patients, about 60% have a response with azacitidine, both on MDS or CMML and autoimmune or autoinflammatory disease. And the same results, interestingly, we've seen in patients with VEXAS syndrome or without VEXAS. So I think this is probably also an interesting drug in this situation, and we generally reduce dose like 5 days in order to reduce cytopenias in those patients who are already immunocompromised. So I think further studies would be probably useful with this drug in this situation.
Yeah, I think 100% agree, Pierre. I don't know, David or Uwe, do you want to make a comment on that?
My comment is I agree, Pierre. It's a very good drug to study, maybe as an oral formulation, giving us more continuous exposure, but I think it's also a little bit, the question is culprit or bystander. What is it like? Would you consider AZA a immunosuppressive drug, or is it rather by targeting the clone? You basically, I think this is always the question, and I now ask Pierre Finot to give an answer.
Our suggestion, in fact, is that it is an argument to suggest that it's not the MDS that causes the autoimmune disease or vice versa. It's rather probably the mutations, especially TED2, that cause both. So if you act on the clone, you potentially, but that's
what I said.
Okay, thanks. Any other questions? David, could I ask you to answer that from a VEXAS perspective in the question, because I think Pierre touched upon the use of azacitidine, not just in VEXAS, but generally around the autoinflammation. But as a practical advice to people sitting here, which group of patients with VEXAS, with or without MDS, would you choose azacitidine over other therapeutic measures like JAK inhibition, which you have some data on, or we've discussed this before?
Yeah, thanks. I think we still are trying to answer that question. I think Pierre's point that hypomethylating agents are probably a good first starting point for a lot of patients with VEXAS. We've tried a lot of the anti-inflammatory medications, cytokine inhibitors, and they haven't been very beneficial, especially for the inflammatory component. So, the two medications we've seen some benefit for are hypomethylating agents and ruxolitinib. And the question is whether or not, with or without MDS, with or without other co-occurring mutations, patients should get hypomethylating agents. I don't think we know, and I think the experience of different centers will tell us, but I think that the general, where my gestalt is, and I think probably Pierre will agree, but I'll make him answer the question, is that hypomethylating agents may end up being first line at some point soon for VEXAS until we have a more targeted therapy.
Yeah. I have a question which addressed to several speakers. What about inhibition of TLR4? Because this has been shown to be beneficial in primary myelofibrosis. What would be the application in MDS? Yeah, maybe.
I think
Maybe.
the way you're poised to
Yes.
answer.
Yeah.
The microphone. Yeah?
Often. Yeah. Over.
Well, no. So I think in general, from the background I provided, I think there's a great rationale to study. Just I'm not aware of any trials at the moment. Maybe I haven't looked precisely, and you know it better than me, but I'm not aware. What I can say is that there has been a study a couple of years ago with a toll-like receptor 2 antibody from Opsona at this time, which produced only minor responses, predominantly in low-risk MDS patients. So I'm not questioning the concept, but I think these kind of agents as an all-comer strategy, I don't think this is what we should do. We should rather identify the subgroup of patients who may benefit and then pre-select and do clinical trials exactly in this subgroup of patients.
Thank you. I think we are running out of... Oh, there is a question quickly from Lars Nielsen.
Thank you. Lars Nielsen from Lund. I have a question for David Beck for VEXAS, because to my knowledge, the UBA1 mutation is not very common in CMML, but apparently they have more autoinflammatory symptoms than many other MDS patients. Do you just think that we have missed some VEXAS-like mutations for these patients, or do we have any points of other mechanisms for the autoinflammatory problems in those patients?
So I think if I can rephrase a little bit, why don't we find more UBA1 mutations in CMML? I think that a lot of the patients with VEXAS that have the canonical mutations have severe inflammatory symptoms that have made it difficult to make a diagnosis for them. Whether or not their cytopenias are secondary to the inflammation, whether or not their blood count abnormalities are the original diagnosis or secondary. So I think a lot of times they're excluded from classic CMML. I think the same question will come up with MDS, whether or not some of the cytopenias are secondary to the inflammation or primary cause. That's why Pierre's point that it's a shared mechanism. But I think there probably are other drivers. We heard about that earlier, that there are other shared drivers that are going to be for these inflammatory hematologic overlap syndromes. So I was surprised too.
Thank you so much, David. And I think, thank you so much. And I think we should wrap up. We don't want to eat into the coffee break. Thank you, everyone.
Thank you.